it's okay not to be okay. Let's find whatever assistance, support, reassurance are available so that we can help each other, so that we can sustain the force with the most important resources that we have is us. If we are not here, how can we take care of others?
Hey everyone, welcome to the Nursing Insights podcast. My name is Stephanie and I'm a registered nurse practicing in the state of New Jersey. Getting right to it, the state of healthcare right now is tough, to say the least. Let's just say that the nursing shortage does not spark joy. We can sit in that and stew in it for a while, but we can't live in it forever. Things are changing. So join me as your host as I partner with the New Jersey Collaborating Center for Nursing to hear from nurses across the state about their experiences, trials, and triumphs in the nursing profession. Today, we have the honor of having Dr. Marthe Leveille, the Director of Nurse Wellbeing at University Hospital in Newark, New Jersey. Thank you so much for joining us today, Dr. Leveille.
Thank you for having me.
So, Dr. Leveille, could you tell us a little bit about the hospital that you're at and the role you have there?
Yes, indeed. So I do work at University Hospital that stays in the heart of Newark, New Jersey. It is a safety net hospital, and here we see patients from, we are a level 1 trauma center. And we are an organization that is focused on high quality care. So one of the things that we focus on is that we are a comprehensive center for stroke services. We're also certified by Joint Commission for heart failure. So a lot of high quality services are offered in the community. Lots of services in the community to look at the chronic diseases, cardiac diseases. We also do liver transplants here at University Hospital. And we have been the number one, I believe in 2024, we were number one hospitals for liver transplants for sustainability of services. So I'm very proud to be here. I have been here since 2001. And I can say that I grew up at University Hospital and very glad to be working in Newark where I can serve the community.
That's amazing to hear. And could you tell us a little bit about your role as the Director of Nurse Wellbeing at University Hospital?
Thank you. That's a great question. About 2.5 years ago, the new CNO, Dr. Maria Brennan, made the wise decision of creating a position of Director of Nurse Wellbeing. We have started some formalized wellness activities at the hospital since before COVID, and we will get to them in a few minutes. However, 2.5 years ago is when the role was actually created and my position was placed into that job description. So the Director of Nurse Wellbeing is responsible for providing wellness activities to not only the nursing staff, not only the patient care services department, but my role extends throughout the organization. It also includes services such as Healthy Workforce Initiative. We have been in a journey to eliminate, really, if possible, eradicate instances of bullying and incivility and create a space where respect, kindness, and professionalism become the new norm. The mission, really, of the Healthy Workforce Initiative is to ensure that we communicate to the staff that the way we communicate with each other is just as important as the way we treat our patient. So communication is important to reduce medical errors and increase not only satisfaction, but allow all of us to work in an environment in a respectful manner with kindness and professionalism.
That's amazing. And I hope to hear more about that one day, because what amazing fruits of your labor. That sounds like a whole other podcast topic that I'd love to. How cool is that? So, Dr. Leveille, today we're really interested in hearing about your DNP project, which is about the second victim phenomenon. Could you tell us a little bit first about what the second victim phenomenon is?
Yes. So the second victim phenomenon has become a passion of mine and has become a journey that I've engaged in. Around 2017, I was enrolled at Rutgers University in my DNP program, and I was debating to solidify my DNP project. At that time, I attended a conference at the ONL New Jersey, Organization of Nurse Leaders, and the keynote speaker was Nurse Susan Scott from the University of Missouri. And there, she described to us what was the impact of the second victim phenomenon, what were the symptoms that they were expressing, and it seems as though a light bulb opened in my mind. And I have realized that not only that maybe I was a second victim, but I work every day with second victims. And the challenge is that there was not a formal program. There was not a space to express how these emotions were coming out and how do we address them? How do we help staff nurses or healthcare providers in general not only surviving difficult situations, not only for them to survive following a medical error, but how do they thrive in order to remain not only in their unit, in their organization, but in their profession? We are losing healthcare workers, seasoned workers, as a result of being second victims and the second victim phenomenon. Second victim is defined as a healthcare provider that has experienced a level of stress that feels traumatized by the event. So when the trauma accumulates over time, you start feeling and expressing some symptoms. Some are emotional, some are physical. So after hearing that keynote from Dr. Susan Scott, I approached her. I spoke to her and let her know that I would like to partner with her in engaging and making it my DNP project. My director was Dr. Edna Cadmus, and as soon as I came home, I sent her an email. I said, by George, I've got it. I got my project. And from then on, we continued the communication. We've done the literature review. We've spoken to other individuals, and we've engaged in the pilot implementation in the intensive care units here at University Hospital.
That's amazing. Dr. Leveille, just for somebody who has maybe never heard the term second victim phenomenon before, could you describe what kind of circumstances creates the phenomenon, or what a second victim or who a second victim may be?
So a second victim, it can be any one of us. A second victim, I'll give you a couple of examples to illustrate what we're trying to say here. As I defined it, the definition according to Dr. Susan Scott, and this term was actually coined by a physician that realized that he too was a second victim. The patient is the first victim, but the healthcare providers are considered to be the second victims as a result of maybe a medical error, maybe a physician in the OR and has operated on the wrong limb. Maybe a nurse in a unit in the ICU or in the emergency department following the death of a patient and is feeling a level of emotion that is referred to as emotional labor. A certain level of stress that is not resolved quickly. And over time, these symptoms develop and cause you trauma. So these individuals are the individuals that are referred to as second victims. The second victim continue to work. We work every day in circumstances that we may feel as though we suffer in silence. because we're not comfortable sharing with others, I gave the wrong medication. Or as it became known as a result of reporting, as a result of maybe an RCA, that your peers are aware that there was a medical error. Now you're feeling guilt. You're feeling shame. And you continue working with these instances that cause you a level of stress that you haven't dealt with, because there's no formal way of addressing these issues. And there has been so many examples of staff members that have gotten to a point where they could not continue working in their organizations or the unit where they were. We have heard of several seasoned ICU nurses, after a couple of years, have made the decision to leave this stressful, fast-paced environment to work in different settings because the stress was definitely unbearable. They express symptoms such as difficulty sleeping, they have trouble sleeping, or they have difficulty eating, their appetite changes. The challenge is that we don't pay attention to these symptoms. We say, okay, on my next day off, maybe I'll have a better night's sleep. Oh, I start gaining weight. Oh, I'll change my diet. But these things are as a result of the stress that we accumulate. Novice nurses that experience their first death is very traumatic for a nurse, for a novice provider. So all of these instances are examples that create the phenomenon of a second victim. So there is a need for us to pay special attention to these instances that not only cause the stress, but cause it to accumulate where there's no outlet for it. There's no open door for a nurse to say, I'm not okay. I'm not feeling well today. I need help. I need to step out. And it is not that my blood pressure is high. It's not my diabetes is out of control. It's not a physical impairment. It's emotionally, the stress has come to a level that I feel traumatized due to the symptoms.
So it's so important that we continue to make a space, as you were saying, Dr. Leveille, for nurses to be able to come forward and address those feelings, and also other providers, as you said, it could be any healthcare worker. As you were starting to approach the creation of your DMP project, what were your thoughts? How did you start thinking about how we could begin addressing the second victim phenomenon in our units?
So the first thing that I thought was very important for us to do, it was a new concept for me. It was a new concept in my organization. We conducted a survey that told us that many individuals had no idea that terminology even existed, that we needed to pay attention to the symptoms that they were exhibiting. So we looked at the survey, we took data from the survey, and we knew that the major thing that needed to be done is education to raise awareness. So we've created a curriculum to educate the staff on the phenomenon, on the definition, the cause, the symptoms that they would be exhibiting, what they should be looking at to understand that, maybe I'm having symptoms as a second victim. It took me not too long after I have researched the topic to realize that at some point I was a second victim. Very early in my career, I was an oncology nurse. And I vividly remember that tall, slim gentleman that I admitted on a Friday afternoon. He walked in and I greeted him. He was a construction worker and was having some cough and some lung symptoms. The physician asked him to come on Friday after work for some examination, and then on Monday he would go back to work and be discharged. I admitted him. I was off over the weekend. When I came on Monday, we had a meeting where we were calling his daughter, who was then in the military, to come and visit. By then, they found that this gentleman was diagnosed with stage 4 lung cancer. The cough wasn't just a simple cough. He was not breathing well. So we started making arrangements for his daughter to come from the military to come and visit. By Wednesday, he was deteriorating. His daughter arrived, spoke to him, and they had some time. I believe she was given 2 days and had to go back on duty. By Friday, I was sitting next to that gentleman holding his hand and counting his breath, waiting for him to give his last breath. That's a week, 7 days to count. That experience I have never forgotten. I was a young nurse. There was not an opportunity for me to tell somebody, I need to go sit somewhere. I can't do it, because I had 6 other patients in addition to him that I needed to tend to. Someone else needed an IV. Someone else needed something else. There were other tasks to be performed before the evening ended. And that night, I went home and started crying. I could not take this gentleman out of my mind. This has been over 20 years ago. I have to tell you, the example is just as vivid in my mind as it was then. So as soon as I read more and learned more of second victim, I realized that I was a second victim. I would have loved at that time to have someone to come and say, are you okay? Go to the break room. Take a break. Take a break before you go back to your patients. Is there something we can do for you? How are you feeling right now? Create a space where I could express what is it that I was experiencing, thinking, feeling versus these patients, my personal emotions, all of that being mixed up while still trying to take care of other patients, trying to smile, say, Mr. Jones, I'll be there for you. I'll do this. And trying to work through that emotional labor that I'm working with. These are the symptoms that create instances where nurses are not 100% emotionally well to address the very challenging situation that they face. So when I put these two together, I saw an opportunity. We need to raise the awareness, not only for the staff working to know that they are experiencing these symptoms, but also for the leaders to understand that when we need to step in and help our staff to function better, to see that it's okay to not feeling okay and seek help. Some nurses may feel triggered by maybe a family member that had a similar issue, and that create these emotions. So we educated about 80% of the ICU staff on the phenomenon. The Susan Scott project calls on pyramid, right? A 3-tier pyramid of second victim interventional, where you can have at the first tier individual with specific training. They don't have to be counselors. They do not have to be psychiatrists, but they are peers that are compassionate, willing to listen, willing to check on each other. So I created a multidisciplinary team that were willing to be peer supporters to the second victims. So the pilot project was to, 1, educate the staff, 2, educate the peer supporters, establishing a team of individuals that would be willing and able to recognize the signs and symptoms of second victim and being willing to address their issues at the moment or as soon as possible, or refer them to additional resources if necessary.
That's wonderful. And so as you moved forward with the pilot, what kind of outcomes did you start to see?
Oh, wow. By the end, it took about almost 9 months, it was my DNP project. By the end of the project, the post-survey definitely revealed that there was an increase of awareness. There was increased interest in the organization to not only learn about the phenomenon, but do something about it. Individuals started talking more about it. They started seeking more information about it. So at that time, I had a different role while still acting in that role and completing my project. And by the end of the project, I met with the stakeholders, the executive staff at that point, and it was not a question. The organization was willing and ready to extend the services to the staff. So at that time, we've made the decision in order to ensure that we can manage the education process, the awareness process. Let's extend it to the emergency department, and we will go step by step, group by group, and work it around. So that was at the end of 2019, early 2020, and we all know what happened in 2020. Early 2020, COVID came at a point where it affected not only the clinical staff, but it also affected the non-clinical staff. The level of stress that we were feeling and experiencing was extended to every healthcare worker. So the executive staff called me and said, Marthe, I know you focused on the clinical staff in terms of the second victim phenomenon, but right now we need something house-wide. So we shifted the gear to extend the awareness session to the non-clinical staff. So we were fortunate at that time to receive some training from Homeland Security. So we extended the number of peer supporters because we extended the number of people that we had to talk to. So we've extended these resources. We've created brochures, we've created flyers, we've rounded, there was regular rounding on the units to allow individuals to be comfortable. There was a level of mistrust. I don't really want to say that 2 weeks ago there was an event and I'm still not feeling well about it. We've connected to the patient safety department so that when there is a safety issue that was reported in our safety reporting, the repository that we have in the organization, that we would connect and ensure that we reach out to this individual. So we've established a system, not waiting for the individual to reach out to us, but that we could anticipate that these circumstances will create a second victim experience. So let's reach out to them. We were very successful in educating the nursing department. We had some challenges with physicians, but we did have some physicians involved in the practice. We've educated the pharmacy department, the lab service department, the social workers also. We've educated them, and all of that is supported in the literature. In fact, the literature supports that healthcare providers do not want to be referred to as second victim. One of the challenges of this project being actually expanded is just the name of second victim. As I mentioned earlier, we are a level 1 trauma center, and the trauma physicians didn't appreciate being called a victim because they see the patients and their families as victims. So why put me in that position? So not wanting to close out the meaningful impact of the project, we conducted another survey asking the staff, how would you want to be referred? What's the name of the program? So the survey was, we need a name. We need a new name. So we sent a survey which surprisingly, this organization has about 2,000 to 3,000 employees. We had close to 800 responses with the survey. We could not believe that there were so many people interested that would read the survey and respond. So they decided, or we gave a list of potential names. So the name of the program was changed from the Second Victim Project to UH Cares for You. University Hospital Cares for You. This program is solely for the staff, for the employees, and not for patients and their families. So University Hospital Cares for You. One of the important outcomes of this project is that the staff understands that as an organization, we pay attention to their needs. We build the level of resiliency that we can help each other. We can support one another, that we can survive these difficult situations. But better yet, the goal is ultimately that we will thrive when we don't just agree that maybe I'm okay, but that I can step forward to help my peer, help a coworker. And as an organization, we can have that level of resiliency that difficult times will come. Challenging times will always be there. Short staffing will be there. We will work short one day or the next. But how do we build that level of resiliency that will help us to overcome these challenges? This program has helped us to have a language to not be constantly in crisis, but all right, we understand there may be a crisis, but how do we engage? How do we help each other? How do we help you? And how do you help me to look into these challenges?
It's so inspiring to hear about, and I'm so glad to hear that it sounds like leadership was really behind you. It sounds like leadership was ready to act,
Yes.
Especially in the time of crisis, as the pandemic you were saying in 2020.
Yes.
I'm glad that leadership was ready to act on behalf of the staff, in support of the staff. So since then, it's now 2025, how has the program expanded? How has the program evolved or changed? And what does that mean for your DMP project? How did it go as your DMP project concluded?
Oh my goodness. So since then, as I said early in the project, we have gotten some training from Homeland Security. But we felt that we needed something to more secure the peer supporters, to help us to understand what are we doing, how are we doing it, what do we say, what do we do. Around that time, I became acquainted with the New Jersey Nurse Emotional Well-Being. With the New Jersey Collaborative, we were able to gather a number of individuals to also take the Stress First Aid program. We got engaged in the Stress First Aid Train the Trainer training. That program actually added the cherry on top. It allowed us to train a number of individuals to have clear language on how do we help others, because we moved out from just the second victim phenomenon following a clinical event. Now we became the supporters for emotional distress. Right? So the Stress First Aid program gave us that opportunity. And we started looking at different resources. What is it that the staff needs? How do we provide these resources, these wellness resources? As we know that everyone was affected by the results of COVID and everything that came as a result of COVID. Right? So we engage, and currently we have about 39 individuals that have completed the Stress First Aid program. So we engage in socializing the stress continuum tool throughout the organization. If you come in the organization, you'll see all of our computers have a screensaver with the stress continuum tool that has the green, yellow, orange, and red image so that staff can see it so often that if they don't know yet about it, they can ask about it. So we socialize that idea throughout the organization. And we've created peer supporters. So we had a steering committee with leaders, and we were meeting monthly. In addition, we also created additional supporters at the unit level. So we've had the unit leaders or the department leaders select a minimum of 2 supporters per unit, per shift, because what we wanted is people that had received training, that were compassionate, that were aware, that could identify the symptoms of both second victims or just high level of stress to reach out to a supporter and say, I believe this person needs help. Maybe you can talk to that individual. Maybe you need to do so. So we've established and organized the system so that we connected the peer supporters to the unit level supporters, the staff level, so that we were constantly in conversation. We created an email address and a direct phone line that they could reach out to us 24/7, any day, anytime, weekends, holidays. If there was a situation that you needed to talk to somebody about an emotional issue, then go ahead and do that. We met with these individuals on a monthly basis to support them. Because we are a unionized organization, we wanted to make sure that we didn't get involved with issues that the managers needed to deal with, right? Issues on the unit that needed to be dealt with, that the staff didn't confuse the roles. So we needed to engage them and ensure that, and we gave them a script into this is what you say, this is what you don't say, this is what you do, this is what you don't do. You have to be clear that we are not counselors, we are not licensed counselors, we are not psychiatrists or psychologists, we are peer supporters, and these are the limitations of our roles. We engage with external organizations so that if there were individuals with serious emotional or mental conditions, that we could refer them at the ready. There were phone numbers, there were information that we've distributed and informed everyone of this. So the peer support group was formed, was organized. We were meeting on a monthly basis. We were rounding. We had gotten referrals of things that we did not expect. Let me give you some examples. I received a call from an individual that says, my friend is in trouble. I need my friend to talk to you. I said, sure. The friend came to my office. When they came, the 2 of them came to my office. And she said, when her friend came to work, she smelled alcohol in her breath. And she saw that the friend wasn't walking or functioning well. And she became concerned. And she told the friend, listen, you can't continue that way. You have to go talk to the people, or I'm going to report you to the manager because you're not safe to work in this situation. So the friend brought her to me. We sat, we had a conversation. We established a contract. We referred her to the addiction service department, and she has some personal issues that she needed to deal with. And she was able to have these services with the UBHC. At the UBHC, we made an appointment for her, and we had a contract that she needed to follow up on these appointments. And we would follow up with her, ensuring that she was improving in her state. She did take some time off so that she could work on herself. And then after a few months, she returned to work.
That's amazing. What an impact.
She was able to return to keep her job because a friend knew the symptoms and realized that let me try to help my friend and be a peer supporter. These were situations that we connected in a way that showed that the program is meaningful. The program reaches the people where the need is. So I'm very glad that I have a team now that works with me, and they are totally engaged. My team of peer supporters include the chaplains. We have the wellness committee involved. We have a psych nurse educator that is involved. We have social workers that have gone to the 3-day train the trainer of the stress first aid training, and they are committed. We have an on-call list 24/7. When there is a need, there is a peer supporter available to respond to their needs.
I love how deeply comprehensive this whole package is, the whole service, from computer screensavers to having the generated report also trigger a warning that somebody is likely in the case of needing extra support, to having the embedded staff members. I think it's such a sign of the trust in the example that you gave, where one of the nurses can say, this is my friend and I want her to have help, so I'm going to bring her to you, because she wants her friend to get better, and she believed that your team and your services would be able to help rather than be punitive. And that is just such a testament to the type of work you've been doing and the reputation of your organization that you've built.
Definitely.
So that is just amazing, Dr. Leveille. Thank you so much for sharing. And my understanding is that you've also received a grant for the work.
That is correct. So as we were developing the program was growing, and 2.5 years ago, my role was actually devoted to wellness activities throughout the organization. So around COVID is when we opened the first wellness room in the organization, because we understood that we need to provide the services right here. The staff doesn't need to wait when they go home to find someone to talk to find a place and a space where they can just go for some mindfulness exercises, some breathing exercises. So the organization supported the initiative. They provided the financial resources, and we've opened a room. We called it the wellness room at that time. And we've had 2 chair massages. We've had the 2 high-level chairs and foot massages, and we had soft music, some aromatherapy in that room that was totally dedicated to the staff. Oh, this was so well received. And over the years, we have improved so much that room currently, we have about 1,300 individuals monthly that frequent that room. We were able to get with these type of reports, and on a given day, we can have about an average of 50 individuals that go through that room. So we wanted to do more. We wanted to extend the wellness room. We have 1 wellness room throughout the organization. Real estate is definitely a hot commodity here. We don't have enough rooms because everything is called for. At that time, the AARP and AACN, they advertised a grant for organizations who wanted to establish programs that would be targeting recruitment, retention of staff in their community, and they would also work with some of the collaborative organizations to do so. We had all of the pieces together already. We were already working with the New Jersey Collaborative. We had already had a group of individuals trained in stress first aid. They wanted us to select 2 goals that we were meeting to actually be awarded the grant. So we selected the priority 3 of the National Academy of Medicine that says that the organization will organize a systematic program for their employees and make sure that they receive these whatever programs that we would set up to do. And we also selected the AACN standard of meaningful recognition. But meaningful recognition in a way that the staff wanted to be recognized. So we've applied for the grant. The grant was for about $50,000. Not too much, but it was 50 that we didn't have. So we took that amount of money. We've opened another wellness room. Around that time, like I said, 2.5 years ago, we had a new CNO who we became engaged in the journey to pathway. So we are actively working toward pathway, and we've chosen our role model, if I should say, to be Jean Watson. So we decided that all of these rooms will be changed to be Watson rooms. So the emergency department had a room that they dedicated to wellness activities. We have taken this room, we have painted this room lavender, we have renovated the room. It looks like something totally different now. We've placed a massage chair in that room, and as a result of the grant, that gave us the funds to actually open another Watson room in the emergency department, because there were concerns that the emergency room staff could not leave and go around where the wellness room was. So we have one right there for them in the emergency department. As a result, we've also connected with our shared governance group. We have the practice council group that meets and give us ideas. They are our connection with the rest of the staff, right? So they spoke to the staff, we distributed surveys, what is it that they wanted to do? And it came to our attention that they also wanted to establish a process of Code Lavender. Code Lavender exists in many organizations, but we didn't formalize the process for Code Lavender. They could call the peer support group, but we wanted to give them something that was more practical for them. So we created a policy for Code Lavender that calls for a phased response, similarly to the peer support response that we've had, but we formalized it under the umbrella of Code Lavender. So we've connected the needs, the Code Lavender process with our access system. So the same way, if there's a cardiac arrest, they would call a certain number. We've connected to that same process if there is any situation that causes emotional distress. The staff knows to call that specific number, and that number will send a pager to all of the peer supporters 24/7, weekends, holidays, and somebody would respond. So we went live with Code Lavender on January 15, and January 20th was Martin Luther King holiday. At 8 a.m., we received a Code Lavender page. So I was so grateful. I was at home actually having breakfast with my daughter when the page came, and I said, oh my God, are they just testing us to see if it really works? But no, there was a real crisis in a unit, and they received the information so well that they knew to call Code Lavender. And we connected to we have 24-hour chaplain services in the organization so that they are our after-hours response services. And holidays as well, holidays and weekends. So we connected with them, and they were able to respond to the individual and provide some emotional support, some assistance when they needed it. So the grant provided us resources to strengthen the programs. We implemented, as a result of the grant, the stress first aid in 10 units. So yes, so we socialized stress first aid since 2020 to the organization, but we didn't followed up. We didn't have the actual implementation where we were actually doing the work at the unit. So we've asked these 10 units that they would have a board with a physical board with the stress continuum tool. And at the beginning of every shift, they have a huddle. There's a huddle that is conducted, and every staff member would do the first core action of stress first aid, which is to check themselves. Check-in means, what color are you today? Are you green? Which means you're fine, you're motivated, you feel that you have the training, you have the supplies, you're doing okay. Or are you reacting? You yellow. Maybe on the parkway you got into an accident and now your car is, I don't know, you came to work, you're not feeling okay. Maybe you got a call from your child's school and you're at work, but something else is happening. What can you do when these things happen to allow you to work or to continue working or to go back to green? Well, you can use some mindfulness practices where you can talk to somebody, maybe have a phone call, establish some initiatives so that you can continue working. So if you don't take care of this and it accumulates, you can move up to yellow. So how many people are yellow? Research has told us that most healthcare workers come to work in yellow or orange. Orange is a critical point in the stress continuum tool. Orange is where you definitely need a peer supporter. It's that time when the stress has accumulated for so long that you can even become injured. You start to lose control. You don't function well anymore. You need peer supporter. At that point, that's when you hear some of your peers saying, I can't do this anymore. I can't take this anymore. I don't know why I came to work today. This doesn't work for me. I'm done with this. When these things are expressed in words or in behaviors, something else is happening. How do we recognize that and help each other? So Stress First Aid call on us educating the staff to consistently check 1 and check 2. Check yourself. How am I feeling today? Am I green? Am I yellow? Or am I orange? And what resources are available to each and every one of us? So it took a lot of time. It took all of these resources. We've created pamphlets. We've reached to other external organizations to let them know if there is something, ask for help. Check yourself. But more importantly, check on your coworker. We spend a lot of time at work. We are the people that can identify my friend is not well. My peer is not functioning well. And I think we've had enough results or notices of staff members or nurses or physicians that have committed suicide. The National Suicide Report tells us that the suicide rate is higher in physicians and nurses than in the general population. This is terrible. This is terrible. We read several instances of staff not showing to work the next day. And when we go and find out and where are they, they're no longer with us. But that's when we see, I saw that he wasn't well the day before. But we thought that, that's part of the job. He'll be all right. He's going home soon or she's going home soon. Let's get into a system and a practice of checking on each other and checking ourselves. It's okay not to be okay. Let's find whatever assistance, support, reassurance are available so that we can help each other, so that we can grow the green, so that we can sustain the force. With the most important resources that we have is us. If we are not here, how can we take care of others? That passion and compassion that we want to extend to others, let us extend it to ourselves. Let's start checking us, check 1 and check 2. So the grant has allowed us to establish resources, programs, and these 10 units had to complete the H-WIT survey that help us to identify where there wasn't great communication. Communication with the leaders, communication with their managers, but communication among themselves. So we had focus group with these 10 pilot units for them to identify. And I think that's the greatness of this program. It is not a cookie cutter program that we come and say, everybody's going to do this. But it comes with how are we going to solve? How are we going to address these issues? After we have checked ourselves, knowing who's yellow in the department, who's orange, at the huddle, we have a discussion. It must be followed in the huddle. So we have trained the champions to lead huddles. If the manager's not available, you can lead a huddle and help your staff have that discussion. Huddles should be no more than 10 minutes. And let's move on. Many of these units were not conducting huddles in the evenings because the leader wasn't there and maybe the huddles were not happening. So we strengthened many of them to ensure that the huddles were happening in the evening. At 7 p.m., a champion, a staff member would lead out in the huddle and have that discussion and identify when something is not well. As a result of this work being done, I get calls right now of even leaders telling me, I think so-and-so may call sick tomorrow. You may want to talk to her because we're going to be short of staff if she doesn't come to work. Or have a conversation with the staff. If you're short of staff today, how are we managing together? How are we prioritizing the work so that we looked at each other, we check on each other throughout the day? Workplace violence is documented as one of the top causes for staff stress. And here at University Hospital, we've had our shares of workplace violence. I have been in a number of conferences lately, and every conference has something with workplace violence. It doesn't matter how you screen them, it may happen. So we talk about how do we check on each other so we protect one another, right? With these instances of workplace violence, or just when someone feels that the workload is getting to you, or where if there's a patient that is difficult, how do we check each other and continue the work? The goal is to build a resilient staff and retain the staff, that the staff doesn't have to leave because it becomes pricey, it's costly to replace a nurse. So increase the retention rate, ensuring that the staff is resilient.
And Dr. Leveille, do you have any of those outcomes to share with us? Have you been able to generate any of that data to demonstrate support of the program?
We do actually. We are actually in the last leg of the grant. The grant started in July 2024. We are exactly at the time where we are writing final reports for the grant. So here are some outcomes that I can share with you. One of the things that this has shown us is that the journey to wellness is a journey. It is a marathon. It is something that must be worked on a consistent basis. It's not an event that you put something together and then it stops. It must be continuous. It must be systematic. In addition, it must connect with several different levels and several other departments. We must all connect in order to build that resilient group. It is not enough to say that we're building the nursing group. How about all of the other multidisciplinary groups that relate to nursing and contribute to the work that we do? So we have several departments that have engaged in improving their communication by strengthening their huddles. And we have seen an increase in team engagement. Now, I shared that the wellness rooms, we have over 50 individuals a day that visit the wellness room. That's great, because if we have these resources and no one uses them, they'll use this. So we want them to be used. In addition, we have gotten many of these units. We are in the process now that we're correlating the increase in communication and collaboration with team engagement and quality outcomes. So yes, when the engagement is increased, we see that the staff is upbeat, there's a reduction in falls. We're able to document at least one unit that has documented 3 months in reduction in falls. So we want these services, this initiative, to continue so that the staff can actually respond and see how they can sustain these services. So we also engage in meaningful recognition, as I mentioned it, and these units, these 10 units as part of the pilot for the grant, they have established an employee recognition program at the unit level. Staff recognition program. Many of them are very low budget. They have a box with post-it notes that every time some positive behaviors, anybody, staff, patients, doctors, co-workers, can write a positive note and they drop it in the box. At the end of the month, whoever has the most post-it notes becomes the employee of the month for that unit. So we have not just one employee of the month for the organization, we have several employee of the month that the staff is recognizing. This has created joy for the units, for the departments, for the staff. We have some that have created a red carpet employee of the month program. There are others that celebrate birthdays on a regular basis. They have a list of birthdays on the wall, and at the end of the month, they bring a cake, they share, they recognize each other, but this is generated by the staff, done with the staff, and it has gotten very great recognition in these different departments. But we went a little further. We used shared governance and asked them, food is not always the only recognition, right? We know that. What are some other things that you would categorize as a recognition? So many of them expressed that they would want to have membership in local organizations. So as a result of the grant, we facilitated about 4 individuals to be members of ONLNJ. We've actually paid their membership fees at ONLNJ. We've also increased the number of staff that has participated in national conferences, in local conferences. So the staff felt recognized. They felt valued at a professional level. And the recognition that they felt is then meaningful. Definitely meaningful. Last but not least, we recently had our Nurses Week celebration. Well, throughout the country, every organization celebrates Nurses Week from the 6th to the 12th. Here in this organization, for the past 3 years, since COVID actually, we've kept the celebration for the month. So at every week for the entire month. But this year, the staff has taken the celebration over. The staff has created a Team Spirit Week where every day they had a different color with different meanings. They had a day that they were dressed as purple because it was Stroke Awareness Day. They had a day of gratitude where we created cards that the CNO sent thank you cards to the nursing staff, but the staff also had cards that they could select anyone to show gratitude towards. We also implemented a unit decoration process. The units had to select a theme and they decorate based on that. Well, This has generated an engagement that we haven't seen before. Team engagement has been the highest. Every unit got together and created a decoration with a theme. And these individuals came from home. They came on their day off to ensure that their unit was decorated. And I have to tell you, judging these units was the most difficult thing that I ever had to do. But the joy, the engagement, the celebration that it brought to the staff, it cannot even be quantified. It is at a high that we are concerned, how do we maintain that level of engagement? So this year, as a result of many of these activities, initiatives, we have seen the highest level of engagement that we've had. And we are actually completing the staff engagement survey, and we're hoping to see the real results, the real numbers that will speak for it there. However, it was felt throughout the organization. Everybody was talking about the engagement of the staff. And we've culminated with a parade of nations. Now, this is something that everyone should see. It became bigger than we could ever plan even for it. We've had about 26 countries participating. So they dressed in their attire, in their country's attire. They bought food that related to that country. And we've had a program with music, with joy. They shared with us things that we probably didn't know to highlight the diversity and the connection amongst the unit. I have to tell you, we have seen a level of engagement as we've never seen before. The meals were succulent, and the staff expressed that they felt very well appreciated. They felt recognized. They felt valued. And we have the staff, we ask that they document on a daily basis what color they are, if they're yellow based on the stress continuum tool. And we do have a graph that shows in January, we had a higher level of staff reporting that they were red. Well, red means you're in crisis. You can't continue working being in red, but you should see the progression. We have about 3 or 4 out of these 10 units that demonstrated that by April and May, there was an increase on number of staff being green or yellow instead of staff being orange and red. So we know that there's so much more work that needs to be done. In addition, we had that nursing administration was working on their end to increase the staffing, right? To ensure that we had the staff. There was a lot of activities being done from the nursing administration point of view. Nursing education was elevating the residency program. So it's not enough to bring them in and recruit them. Yes, we do introduce this program from orientation to them, but we have to have different ways of retaining them. And nursing administration reports every month that there's a decrease in turnover and an increase in retention of staff. So overall, we see the cycle, it's really bringing the fruits that we were expecting. Just to follow through, we are in a partnership now with Rutgers University to look at a research project. One of the challenges of such program in any organization is that we do not have enough financial analysis of the program. Johns Hopkins actually has a similar RISE program, and they are, to my knowledge, the only program that has documented, that has published a financial analysis of a peer support group and the benefits that they've had. And according to their research, they were able to document $1 million in 1 year that they saved as a result of the RISE calls that they were having. So we know that there's benefits. but this is healthcare. It needs to be documented. So we are entering into a partnership with Rutgers to help us to document not just the activities and the initiative, but to look more closely into the financial impact of the program to really document the benefit of all of these connection programs that ultimately will build resiliency, decrease burnout, increase team engagement, and improving retention. And with that, we're not only surviving the storm that may come any day, we want to be a thriving organization.
Dr. Leveille, I can't thank you enough for sharing about all of the amazing work you're doing for your employees. I mean, I don't think I've heard such a resounding success of really pulling an organization together around nurse and healthcare worker well-being. It has been so inspiring to hear about all the work you've been doing. So thank you so much for all that you do for your staff and for sharing, that amazing work that you're doing with us here today on the podcast.
Thank you for having me.
We have one final question that we ask every nurse that comes on the podcast. It's very relevant to the topic that we've been talking about now, which is that we know as individuals and as nurses, just as you've been sharing for this last conversation, that we also need to take care of ourselves. And we wanted to ask you, Dr. Leveille, what is it that you do to take care of yourself at the end of the day?
Oh, what do? I take a walk every afternoon. I go on a walk. I get home. When I do get home at a certain time, I engage in maybe 3 to 4 miles walk. Not necessarily a brisk walk, but a walk in nature that helps me to shift my thoughts process, to take me away from work and back to a different environment. So I find that these walking processes, the walking in nature, is very helpful to me. I also engage in mindfulness practices. I find that breathing exercises help me to reconnect and take myself away from the chaos and back to a point where I can decide where I am today. What's important for me right now? Be present whether I'm at work, at home, take time with my family, and enjoy time with my family. I love to travel. Every chance I get, I travel to reconnect again. That's part of my self-care. So I walk, take time with my family, and when I get a chance, I go away.
Thank you so much, Dr. Leveille. It has been such an inspiring opportunity to speak with you, and we hope to see you again.
Definitely. Thank you for having me. This is a topic that I'm very passionate about, and as a profession, as an organization, we can build more resilient professionals.
Thank you, Dr. Leveille.
Thank you.
Thanks for listening, everyone. We'll see you next time on the Nursing Insights podcast.